falling oxygen saturation. What is apnea? Complete cessation of airflow for more than 10 seconds is known as apnea. What is hypopnea? Airflow reduction more than 50% for more than 10 seconds is known as hypopnea. What is oxygen desaturation? If there is more than or equal to 4% drop from baseline or lost recorded value for more than 10 seconds or SpO2 levels less than 90% is known as oxygen desaturation. So what is OSA syndrome? Obstructive sleep apnea syndrome is a clinical entity consisting of excessive daytime sleepiness and other symptoms such as unrefreshing sleep, poor concentration, fatigue, and morning headaches. Coming to the epidemiology of obstructive sleep apnea, the middle age it is more common, approximately seen in 4% in men and 2% in women. It is estimated that 80% of patients are undiagnosed, with sleep study data estimating sleep disordered breathing having a prevalence of 24% in men and 9% in women. What are the risk factors or predisposing factors for obstructive sleep apnea? It can be classified into 4 causes. Coming to the general causes, male gender, age more than 50 years, family history of OSA, smoking, and associated medical conditions like obesity with body mass index more than 35 kilograms per meter square, history of hypertension, diabetes mellitus, or chronic nasal congestion or asthma. And coming to the physical characteristics of the airway, large neck circumference more than 40 centimeters or 16 inches, micrognathia or retrognathia or any other craniofacial abnormality, narrow upper jaw, enlarged tonsils or soft palate, enlarged tongue, most commonly seen in Down syndrome, and airway muscular weakness due to valvular palsy. Central causes, neuromuscular disorders like muscular dystrophy or polio, reduced respiratory drive, secondary to neurological insight because of CVA or head injury, and use of sedative agents like benzodiazepines and alcohol. All of this leads to obstructive sleep apnea. OSA is strongly correlated with obesity, in particular morbid obesity, that is body mass index more than 40 kilograms per meter square or body mass index of more than 35 kilograms per meter square with significant comorbidities. It is found in 40% of obese females and 50% of obese males. Why? It's because in obesity or in morbid obese patients, there will be decreased tidal volume, decreased vital capacity, decreased expiratory reserve volume and total lung capacity, and also functional residual capacity. But residual volume remains normal. Lung compliance also remains normal, but chest wall compliance decreases because of increased weight of the chest wall due to adipose tissue formation, as well as abdomen contents press against the diaphragm and make respiratory excursions of the diaphragm difficult, which leads to increased work of breathing, which subsequently leads to increased incidence of obstructive sleep apnea in morbidly obese patients. Coming to the pathophysiology, obstructive sleep apnea is most commonly seen during REM sleep because the body is in its most relaxed state during the REM sleep. During this state, tone of the phalangeal dilator muscles like musculus genioglossus and musculus henoglossus decreases, which leads to pharyngeal airways collapse, leading to airway obstruction. Because of airway obstruction, there will be increased respiratory efforts, inspiratory efforts increase, which leads to increased negative pressures produced by the diaphragm and intercostal muscles, which also promote a collapse of the oropharynx. With airway obstruction, inspiratory efforts increase as there will be arterial oxygen desaturation. It leads to partial arousal from sleep and a sudden opening of the airway, which further leads to short period of hyperventilation until sleep deepens and airway obstruction recurs, which leads to repeating of the cycle. The result is the blood gas oscillation and sleep fragmentation. In obese patients, increased adipose tissue in the neck and lateral pharyngeal walls narrows the airway further, leading to the airway closure during the sleep. In non-obese patients, tonsillar hypertrophy or craniofacial skeletal abnormalities may lead to airway narrowing and sleep apnea. Mainly neurological in OSA patients, neural control mechanisms generating pharyngeal dilator muscle stones are active in the awake state to overcome the relatively smaller upper airway. But during sleep and anesthesia, it attenuates the pharyngeal dilator muscle activity. It is this combination of anatomical structure and neural compensatory mechanism which leads to the development of OSA. Now coming to the clinical features, the patient may present with choking or gasping during the sleep, snoring, sudden awakening to restart the breathing, waking up instead during the night, feeling tired in the morning, headache, daytime sleepiness, lack of concentration, fatigue, irritability, gastroesophageal reflux disease, and sexual dysfunction. What are the physiological changes that arise from repetitive airway obstruction? Repetitive airway obstruction may lead to arterial hypoxemia, arterial hypercarbia, polycythemia, systemic hypertension, pulmonary arterial hypertension, cardiac rhythm disturbances, and right ventricular failure. There is an increased incidence of heart disease, cerebrovascular events, and also sudden death. Coming to the diagnosis of obstructive sleep apnea, obstructive sleep apnea can be diagnosed from the patient's history, where he can tell the clinical features and examination of the person. Predisposing conditions combined with a history of snoring, restless sleep, headache, and daytime sleepiness should alert to the possibility of obstructive sleep apnea syndrome. Coming to the screening tools, the most commonly used screening tool is stop bank questionnaire. Others like the Berlin questionnaire, the ASA checklist, Clemens criteria, Epworth sleepiness score can also be used. Stop bank questionnaire. In stop bank questionnaire, there will be 8 points where we have to evaluate, and 1 point is received for each positive answer. S stands for do you snore loudly enough to be heard through the closed doors by others. T stands for do you feel tired or fatigued during the daytime. Has anyone observed that you stop breathing or choke or gasp during the sleep? P. Do you have a history of high blood pressure with or without treatment? B. Body mass index greater than 35 kilograms per meter square. A. Age over 50 years. And neck circumference greater than 40 centimeters or 16 inches. And male gender is also one of the points. 0 to 2 first points is considered as low risk, 3 to 4 intermediate risk, and 5 to 8 is considered as high risk patients. Polysomnography or sleep study. Polysomnography examinations include recordings of the heart rhythm, electroencephalography, blood pressure, eye movements, electromyography, snoring volume, oronasal airflow, and peripheral pulse oximetry are also usually recorded. PSG identifies sleep architecture, number and degree of arousals during the sleep, number and type of apneic episodes, episodes of oxygen desaturation and severity, cardiac arrhythmias, limb movements, disorders associated with REM sleep, and also seizure activity. Polysomnography grades obstructive sleep apnea depends on the apnea-hypopnea index. The apnea-hypopnea index is the number of apneas or hypopneas recorded per hour of sleep during a sleep study. Its normal value is less than 5 per hour, and in case of mild obstructive sleep apnea, it is 5 to 15 per hour. Moderate obstructive sleep apnea, 15 to 30 per hour, and severe OSA, it is more than 30 per hour. And polysomnography is labor intensive and costly, and there will be long waiting list in the sleep clinics. So there are some home respiratory studies where we can grade obstructive sleep apnea. One of the most used is overnight pulse oximetry, where it measures oxygen desaturation index, that is ODI. A 4% decrease in SpO2 is considered significant in ODI index. Less in decrease in SpO2 that stay at or above 90% is mild OSA, 80 to 89% is moderate OSA, and less than 80% is considered as severe OSA. Coming to the implications for anesthesia, OSA is associated with increased perioperative morbidity and mortality. The perioperative risk increases in proportion to the severity of the obstructive sleep apnea. Sedation, analgesia, or anesthesia leads to potential loss of airway caused by the use of anesthetic, sedative, and opioid drugs. Difficult intubation and postoperative respiratory depression and airway obstruction are also possible in case of OSA. Anesthetic agents such as sedatives, hypnotics, opioids, and muscle relaxants all worsen airway instability, central sensitivity to hypoxia, hypercapnia, and respiratory muscle function, which leads to more frequent and severe apneas. Combined with the metabolic and cardiovascular response to surgical stress, there is significant risk to the patient undergoing major surgery. Patients with OSA have over the double the incidence of postoperative oxygen desaturation, respiratory failure, cardiac events, and unplanned ICU stay. So coming to the perioperative management, first step is preoperative assessment of the patient. For elective surgery, a thorough approach well in advance of the surgery is ideal so that investigations can be performed to assess the risk and plan appropriate care. For the emergency patient, more rapid assessment tools can be utilized to risk stratify the patient and formulate a safe management plan. History. A history for symptoms such as shortness of breath, chest pain, syncope, and fatigue should be taken. Exercise tolerance should be assessed and measured using the New York Heart Association score and explored further by quantitative tests where there are concerns. We need to establish the associated comorbid conditions like cardiovascular problems, which include hypertension, ischemic heart disease, hypercholesterolemia, heart failure, arrhythmias, cardiopulmonary, and also cerebrovascular diseases. Metabolic syndrome causing insulin resistance or diabetes should be evaluated. Gastrophageal reflux disease and osteoarthritis are also common in OSA. Coming to the examination, whether we have to examine if there is an increased BMI, shortness of breath on exertion or at rest, resting hypertension and tachycardia, signs of right heart failure like increased JVP, parasternal heave, tricuspid regurgitation murmur, hepatomegaly, and peripheral edema. A full airway assessment, including neck circumference, whether it is more than 40 centimeter, this is significant. Mallampati score, neck mobility, that is Atlanto-occipital mobility, assessment of dentition, tongue size, and mouth opening should be performed in full airway assessment. Coming to the investigations, full blood count should be evaluated to rule out polycythemia, urea and electrolytes for renal impairment, secondary to the hypertension, liver function for hepatic congestion or non-alcoholic steatohepatitis, and blood glucose levels. ECG may reveal arrhythmia such as atrial fibrillation, right ventricular hypertrophy, right axis deviation, or right ventricular strain. ABC, arterial blood gas analysis, is usually not performed routinely, but it is useful to assess arterial SpO2 and also to assess carbon dioxide retention in OSA patients. A baseline oximetry reading of less than or equal to 94% is suggestive of severe OSA. Full pulmonary test may be necessary in case of respiratory disease, poor exercise tolerance, or ABG. Echocardiography is indicated to assess right heart function and identify pulmonary arterial hypertension in patients with established OSA, where the surgery is of high risk or of lengthy duration. Coming to the preoperative treatment, the gold standard of treatment for OSA is the nocturnal use of nasal continuous positive airway pressure, that is NCPAP delivery devices. BiPAP and variable VPAP can also be used. A nasal mask provides positive airway pressure to the pharynx throughout the breathing cycle. Pressure requirements range from 5 to 20 centimeters of H2O depending on the severity of the obstruction. Preoperative use of nasal CPAP may lead to improvement in conditions prior to surgery and better postoperative compliance with the device. Mandibular advancement devices may be used for mild OSA. These devices position the mandible forward, pulling the tongue away from the posterior pharyngeal wall. Coming to the optimization of the comorbid conditions. If appropriate, weight reduction can be encouraged, and also optimization of diabetes and hypertension should be taken care of. Coming to the preoperative planning, elective surgery should be postponed until the patient has been fully investigated and treated. Patients using nasal CPAP are required to bring their device to the hospital, and staff involved in their care from the recovery room to the ward need to be familiar with its use. Coming to the intraoperative management, high-risk patients should be managed by a senior anesthetist and surgeon. Monitoring includes pulse oximetry, ECG, non-invasive blood pressure, respiratory monitoring, and also invasive arterial monitoring in severe sleep apnea. Pre-medication, benzodiazepines as pre-medication relaxes upper airway musculature, reducing the pharyngeal space, which leads to hypopnea and consequently hypoxia, hypercapnia preoperatively. So ideally, all sedative pre-medication should be avoided or used extremely cautiously. Choice of anesthetic technique, local or regional anesthesia should be the preferred technique whenever possible. General anesthesia with a secured airway is preferred to deep sedation without a secure airway. Laryngeal mask airways are generally not recommended in OSA patients. Coming to the intubation technique, OSA itself predisposes to the difficult intubation. The ASA difficult airway algorithm offers guidance regarding the difficult to intubate patients. Equipment necessary to handle a difficult airway should be readily available prior to the induction. Pre-oxygenate adequately in a ramped position. Laryngoscopy should be performed in the optimal sniff position. Consideration of an awake fiber optic intubation should be made if an airway problem is suspected. Ventilation and oxygenation must be adequately maintained to avoid hemodynamic changes associated with hypoxia and hypercapnia. We need to be aware of the gastroesophageal reflux disease due to hypotonia of the lower esophageal sphincter, and we have to consider a rapid sequence induction. Adverse effects associated with difficult airway management includes death of the patient, brain injury, cardiorespiratory arrest, airway trauma, and damage to the teeth. Extubation is the most important step in case of OSA patients. Tracheal extubation should be carried out with the patient conscious, communicative, and breathing spontaneously with an adequate tidal volume and oxygenation. Extubation should be performed in the semi-upright or lateral position, not in the supine position, only after complete reversal of the neuromuscular blockade. Non-supine position should then be maintained throughout the recovery period. Consider extubating directly onto the patient's own CPAP machine. Coming to the postoperative management, respiratory depression and upper airway obstruction with repetitive apneas are common immediately following extubation in patients with OSA. Supplemental oxygen should be administered continuously to all OSA patients until they are able to maintain their baseline oxygen saturation with breathing room air. Oxygen administration will not prevent apnea, but it may reduce the duration of apnea and the degree of resulting oxygen desaturation. Postoperative nasal continuous airway pressure shown to reduce the risk of developing complications. Patients undergoing upper airway surgery may benefit from a prolonged period of tracheal intubation postoperatively in view of the potential for significant airway swelling. Postoperative analgesia. During the first 3 days after surgery, pain scores are highest, resulting in increased analgesic requirements with an associated risk of respiratory depression. Regional anesthesia techniques are the preferred methods of postoperative analgesia. A multimodal approach to analgesia, paracetamol, NSAIDs, tramadol, ketamine, clonidine, or gabapentin can be approached. If opioids are required, titration of a short-acting opioid analgesics under close observation with continuous oxygen therapy is advised. Monitoring of the patient is must in the postoperative period through continuous pulse oximetry. The ASA recommend OSA patient should be monitored for 3 hours longer than usual before being discharged from a facility. Monitoring should continue for at least 7 hours after the last airway obstruction or hypoxemic episode. So this is the algorithm which shows post-operative management of a patient who has undergone surgery with OSA. So in case of non-moderate OSA, that is AHA 15 to 30 or suspected OSA, we have to rule out if there are any respiratory events during prolonged recovery. That is respiratory events, respiratory rate less than 8, SpO2 less than 90%, or apnea more than 10 seconds. If there are no respiratory events during prolonged surgery in these two cases, we have to rule out whether it is a high-risk surgery like large abdominal incisions, upper GI laparoscopic procedures, or hip or knee arthroplasty without regional anesthesia, or if there is an excessive requirement or excessive opioid requirements, or significant comorbidities like heart failure, arrhythmias, uncontrolled hypertension, cerebrovascular disease, metabolic syndrome, BMI more than 30 kilograms per meter square. If there are no risk factors, then if there is an requirement of post-operative opioid parenteral requirement, then we have to consider for post-operative continuous SpO2 monitoring, and patient's own CPAP is prescribed. If there is an requirement of oral post-operative opioids, we need to admit to ward and overnight monitoring is advised. Patient's own CPAP is prescribed. If there is none requirement of the post-operative opioid, can discharge the patient. In case of severe OSA, diagnosed with severe OSA preoperatively with AHA more than 30, we have to consider post-operative continuous SpO2 monitoring, and patient's own CPAP is prescribed. So this ends the discussion. Thank you.
Good morning. A patient of Pickwickian syndrome on ventilator with a PaCO2 of 100, how do you reduce the CO2 levels, and what is the formula for reducing PaCO2?
Sir, can you please repeat the question, sir?
Pickwickian syndrome is on ventilator with hypercapnia, PaCO2 of 100.
Okay, sir.
You want to reduce the PaCO2 levels. What is your plan and what is the formula? How do you reduce PaCO2 levels? A patient on ventilator. You cannot reduce PaCO2 from 100 to 40 within a span of 2 hours, no?
Yes, sir.
So tell me, how do you plan? Shall I tell?
Sir, please, sir.
Your aim of reducing PaCO2 should be not more than 20 to 40 mm per 12 to 24 hours. And the formula is desired minute volume is equal to present minute volume into present PaCO2 by desired PaCO2.
Okay. Sir, what will happen if you more CO2 falls down faster?
Vasoconstriction వచ్చి బీపీ అవన్నీ అవుతాయి అనుకుంటాం సార్.
Vasoconstriction or vasodilatation, sir?
hypercapnia, vasodilatation, sorry, vasodilatation.
ఎందుకంటే మామూలుగా ఆస్థమాటిక్ పేషెంట్స్ లో ఐ హావ్ సీన్ వన్ 20 years young lady, severe acute exacerbation, came with 220 PCO2 with little bit of drowsy with alcohol. This one in from Banjara Hills when I was in the Jams Institute. So aggressively, as like heroism, I put her on ventilator, and at the time I was just resident. At the same time, consultant came. Okay, then we have put at the time the concept of asthma, 12 respiration. It is there since many decades, but we were not aware of it. So aggressively, our goal is to reduce the PCO2, and I really feel that so young lady, and she expired because of hypotension, and really horrible situation. It's pathetic, because we are thinking that we are doing good, but that's aggressiveness where collapsed because of not. We came to know only later. At the time, we don't know. We thought disease has caused the patient to expire. That was the thinking at the time, but it's not true. It is what we kill the patient. Srikanth,
Sir,
listen, this was a true incident for me.
no, sir. I was actually thinking what is the desired PSCO2 to calculate that formula.
Huh?
Actually, I was thinking
sir?
what would be the desired PSCO2 to calculate that formula, sir.
Desired PSO2 is 20 to 40 millimeters less than the present value. ఇప్పుడు 100 ఉందనుకో.
That's a maximum. It should not be more than that. That's the main reason. There's no desired value. Even you see, for a potassium, for a sodium, for everything, we have the same methods, no?
Yes, sir.
When we do, it's not the correction. It's even look at it. That's why everybody say aggressiveness is not good and slow is not good. It should be moderate.
Sir, I have one more question. NIV pressure control and NIV pressure support. When we should use, when you should prefer pressure control or pressure support, NIV?
So actually, sorry, it may not be the right forum to talk, Srikanth. Round Prasad sir.
Sir.
మామూలుగా ఇప్పుడు మీరు గమనించండి, సోడియం ఇవ్వండి, పొటాషియం అవనివ్వండి, మీరు ఇప్పుడు చెప్పే PCO2 అవనివ్వండి, ఈవెన్ టెంపరేచర్ అవనివ్వండి. టెంపరేచర్ ఫాస్ట్ గా కరెక్ట్ చేస్తే ఫ్రాస్ట్ బైట్స్ వస్తాయి, లేదంటే అరిథ్మియాస్ వస్తాయి. అట్లా దీస్ థింగ్ షుడ్ బి కరెక్ట్. దేర్ ఇస్ ఎ సర్టన్ లెవెల్. ఈ అవర్స్ లో ఇంతకంటే చేయాలంటే డిమైలినేషన్ వస్తుంది. సో దే షుడ్ బి ఇన్ మోడరేట్. దేర్ ఇస్ ఎ సర్టన్ టైం పీరియడ్, సర్టన్ వాల్యూస్. సో దట్స్ ఎ వెరీ ఇంపార్టెంట్ పాయింట్ ఫర్ ఎనీథింగ్ కరెక్షన్. Am I correct, Srikanth?
Yes, sir. Sure.
Yes, sir.
Thank you.
Good morning, sir. Sir, Dr. Shakuntala, sir.
Good morning, ma'am.
Sir, regarding pressure control, when to use pressure control and when to use pressure support, does that depend upon the minute volume, sir? If the minute volume is desired and we need to open up the airways, pressure support will help in the process. And if the desired minute volume is more, then we can give pressure control, sir.
There is nothing like that, ma'am. Minute volume is dependent on your respiratory rate and breath volume. Am I right?
Yes, sir.
So the minute volume required for the patient may be because of the body weight.
Yes, sir.
And
if we could,
yeah,
sir, please, sir. Please, sir.
If you could.
If the patient is able to maintain the minute volume, then it depends upon whether we want to keep the airways open and pressure support will do, sir. And if the patient is not able to maintain the minute volume and unconscious, then we will go.
First of all, two modes of ventilation you are talking the different modes. One is a pressure support see there is TLC, that means tender loving care. That means when the ventilator is there, triggering, limitation and control. These three things are important, TLC. In that, what is a trigger? When you are going to the pressure control is a total control mode. You are controlling everything. Pressure support is when the patient is there supporting himself, you are just only extra supporting. So total two modes are different. You cannot compare two modes at all. You never control. When do you want to control? The control modes has to be compared. Number one, there is no comparison of any mode. Depends on the patient. Synchronization and the reaching of the targets are important. What are your targets exactly to do anything? That's the first thing. And what type of patient you are giving a ventilation? There is a four types of hypoxia. Hypoxia, neurogenic hypoxia, like that you have a different hypoxia. That's only one reason for ventilation, but a lot of other reasons are there. Neurogenic, like neurological problem, or lung pathology itself, or anesthesia purpose. So these four things are different. When you give anesthesia, patient is totally conscious, there is no muzzle relaxant, and at the time of weaning time, then you may try for pressure support. Otherwise, pressure support is dangerous because it actually increases the work of breathing. Because in ventilation, whenever you put a ventilation, only four things are important other than the minute ventilation, these kind of things. Your important thing is what is the work of breathing, synchronization is happening or not happening, and what is the driving pressure particularly, and are you doing more harm and benefit. So the ventilator itself is not at all a treatment, it's only supportive. So except for pulmonary edema or sometimes only for temporary. So with this, you cannot compare pressure support and pressure control. Pressure support is given at the time of weaning. Pressure control is given at the time of treatment of the patient with the full control of the patient of this one. In the pressure control, what is different is this? Pressure control means the limiting factor is the pressure. If it reaches the certain level of pressure, it is going to turn off by its inspiration to the expression. So the desired tidal volume may not reach. The patient on pressure support ventilation or pressure control ventilation, tidal volume. So you have to continuously monitor the tidal volume. If the tidal volume is improving, that means lung compliance is improving. If the tidal volume is not improving, that means lung compliance is not good. So at the time, it is more dangerous. It may have more stress and strain of the lung alveoli will increase. So then the damage of the lung will be more. So that is the reason if the patient is having a compliance low, even in the pressure control mode, you put the patient on full sedation and relaxation and wait for the tidal volume. Still it is not reaching. It is a pathology at the lung itself. So that time you have to go for a tidal volume, accepting the peak airway pressure little may be high, but a plateau pressure is up to 30 to be maintained and accepting the PCO2. So that is a norm of ventilation whenever we do. So there is no comparison of pressure support and pressure control. As you said rightly, the pressure support can be given when the tidal volume is reaching and the respiratory rate is proper. So the work of breathing calculation is important here. The depth, the rate, and the comfort and the synchrony. These things should be seen when the patient is on ventilator.
Thank you, sir. Thank you so much for the detailed explanation.
I don't know whether I really explained you or not fully, Shakuntala, but if there is any query, please ask me again.
Sir, well explained, sir. Thank you, sir.
Why we should not use LMS in these cases, as mentioned in the slide?
Shakuntala garu kada cheppali.
Gayatri sir, speaker.
Gayatri kada cheppali.
Or Kiran also, sir. No problem.
అసలు ఉన్నారా లేదా వాళ్ళు?
Hello, sir. Good morning, sir.
Yeah, Kiran.
Good morning.
There are speaker out of network. Okay. Why LMA should not be used? Voice display?
దాంతో డిఫికల్ట్ మెయింటైన్ చేయడానికి చాలా డిఫికల్ట్ అవుతుంది LMA.
కాదు కిరణ్ వచ్చినట్టు లైన్ లోకి.
సార్
అదే కిరణే మాట్లాడుతున్నారు సార్. ఈవెన్ విత్ ప్రోసీల్ LMS మోడర్న్ ఉన్నాయి కదా, ఈవెన్ విత్
శ్రీకాంత్ నువ్వు దేనికి చెప్పేది LMA?
మేనేజ్మెంట్ లోని ఎయిర్వేలో అంటే షీ హాస్ గివెన్ అ పాయింట్ దట్ లారెంజియల్ మాస్క్ ఎయిర్వే షుడ్ బి అవాయిడెడ్.
అదే దేనికి కొంచెం లేట్ గా జాయిన్ అయ్యాను నేను క్లాస్.
ఈ కేసెస్ లో సార్, OSA కేసెస్ లో అనస్థీషియాకి దే షుడ్ బి అవాయిడెడ్ అంటే ఎందుకు అని.
The control over the airway is lost, sir.
Yeah, definitely not perfect. Yeah.
Even with modern LMS, Procil LMS and all.
Whatever. All those are not comparable with cuffed tubes kada.
అంటే ఓకే, రిలేటివ్ కాంట్రాఇండికేషన్ ఇస్ ఫైన్ సార్. అంటే అంత అబ్సల్యూట్ స్టేట్మెంట్ అన్నది ఎంతవరకు జస్టిఫైడ్ అని ఆలోచిస్తుంది. లైక్ కంప్లీట్ బ్యాన్ ఆన్ యూసేజ్ అన్నది ఇట్స్ కరెక్ట్ అని
కదా. షుడ్ నెవర్ బి యూజ్డ్ అనలేదు కదా.
షుడ్ నాట్ బి యూస్డ్ అన్నట్టే ఉంది సార్ అక్కడ. చెక్ చేద్దాం.
తెలియదు ఎందుకంటే ఒకసారి మనం సరే నో ప్రాబ్లం. దట్స్ ట్రూ.
అంటే మేబీ రాణి మేడం షుడ్ షో సమ్ లైట్.
Yeah, she is more expert. She's there.
In the West they use more, sir. Even
Sir, Srikanth sir. Sir, it's generally not recommended అన్నాను సార్. షుడ్ నాట్ బి యూజ్డ్ అనలేదు. బికాస్ రిస్క్ ఆఫ్ ఆస్పిరేషన్ ఇవన్నీ ఎక్కువ ఉంటాయి కాబట్టి. అంటే generally not recommended what I told you, sir.
Good morning, sir.
Good
As the speaker said, yes, and generally not recommended, but if it is a difficult airway and we are not able to intubate, obviously we'll put an LMA to save the patient and for the airway management. So it's not totally avoided, but it's not recommended, as she said, right? Because there will be a problem. But with the use of the advanced LMAs like the Procil LMAs and all, I think it is not an issue.
Yeah, thanks.
Hello.
Madam.
Hello. Hi. It's not absolute contraindication, but as Gayatri said, these are obese patients and high risk of aspiration. All these are there, and proper fitting of LMA may not be that easy in these cases. And also, like they usually have a little reflux problem, most of them. So they have some irritable airways also. So they need to be really deeply sedated, or they need to be in really deeper planes to tolerate the LMA. And most of the times the idea of LMA is to we avoid a neuromuscular agent, and we keep them on spontaneous breathing. So if they have to tolerate this LMA, they have to be really deep and give good dose of induction agent and good dose of opioid. With that, if we leave them on spontaneous breathing, obviously they'll have more apneas. As such, they'll have apneas, and with all these agents, they'll have more apneas. We'll end up on bagging the patient in between. And bagging also, we have to be very careful. We can't give too big breaths and causing more regurgitation risk, more pumping more air into stomach, causing regurgitation risk. So that's also a problem. And for short procedures, quick procedures, we can use, but taking all due precautions, like if the procedure is like Trendelenburg procedure, though it's a short procedure, but if we have to put head down procedures and all that, we should avoid that. And if it is short procedure, we can keep them on slightly head up position and try and maintain and all that. Probably we can use. And as Chaitanya said, we always have LMAs in the airway trolleys. So if there's a difficult intubation to maintain the airway, to oxygenate them, we can use, but in that situation, for surgical purpose, maybe we have to postpone the case and plan for fiber optic intubation if it is a major case or if it can't be done very quickly. So I think this is what regarding LMA in OSA and obese patients in general. Thank you.
Thank you, ma'am.
Thank you.
Omkar, any inputs?
No, sir. Only one question, sir, about PCO2. How frequently we should do ABG, sir, if we are targeting certain PCO2?
ఆల్రెడీ టార్గెట్ కూడా 12 గంటలకే చెప్పాడు కదా జగదీష్.
హలో
జగదీష్,
సార్ చెప్పండి సార్.
ఏబిజి మన పిహెచ్ లెస్ దాన్ 7.2 ఉందనుకో, ఎవ్రీ 1 hour 2 hours చేసేయండి. ఇప్పుడు మీకు పిహెచ్ కరెక్షన్ ఇస్ మోర్ ఇంపార్టెంట్ అండ్ పీసీఓడి. ఎందుకంటే పీసీఓడి పేషెంట్ చచ్చిపోడు కదా వెంటనే, మరీ ఎక్కువ అవుతే తప్ప.
అవును సార్.
సో ద డిజైర్డ్ వాల్యూ చెప్పింది ఎందుకంటే 12 డిజైర్డ్ వాల్యూ చూడడానికి చేయాల్సిన 12 hours కి.
ఓకే సార్.
ఎప్పుడు నువ్వు ఇంతకుముందు సేమ్ ఇదే క్వశ్చన్ అడిగా ఒకసారి నాకు గుర్తు క్లాస్ లో. అంటే మొదటి రోజు మనం ఎక్కువ సార్లు చేస్తాం, స్టేబుల్ అయిన తర్వాత మన షుగర్స్ లాగే.
ఓకే సార్. ఓకే.
స్టేబుల్ అయిన తర్వాత తక్కువ సార్లు చేస్తాం. డిపెండ్స్ ఆన్ యువర్ మన రూల్ ప్రకారం ఎన్ని చేయాలంటే డిపెండ్స్. మనం సిఏబిజీ ఇంతకుముందు ఎవ్రీ 1 hour చేసాం. ఇప్పుడు సిఏబిజీలో కూడాను బాబు ఎక్కువ చేయకండి ఖర్చు అంటారు కాబట్టి మనం వీ హ్యావ్ టు సీ ద, అంటే ఎనీ ఇన్వెస్టిగేషన్ యూ షుడ్ డూ, నాట్ జస్ట్ టు నో హౌ ఇట్ ఈస్ కరెక్టెడ్, ఆల్సో ఇట్ హ్యాస్ టు బి వాల్యూడ్ ఫర్ యువర్ ట్రీట్మెంట్ చేంజ్, ఇంక్లూడింగ్ ద ఏబిజీ. సో మామూలుగా పీసీఓడి చూడడానికి 12 hours గ్యాప్ ఇవ్వాలి, బట్ పిహెచ్ తక్కువ ఉంటే మాత్రం మోర్ ఫ్రీక్వెంట్ చేయాలి సార్.
ఓకే సార్.
What is the taste and odor of commercially available carbon dioxide?
లేదు సార్.
Commercially available carbon dioxide is odorless and a taste of soda.
సోడానా? ఇది మన బయట సోడా వేస్తారు అదేనా?
అదే సార్.
అందులో కార్బన్ డైఆక్సైడ్ ఫిల్ చేస్తాను అనుకుంటా కదా సార్, గోలీ సోడా. సోడాలో కార్బన్ డైఆక్సైడ్ ఫిల్ చేస్తాడు అనుకుంటా కదా సార్ గ్యాస్.
అవును అవును అనుకుంటా నేను కూడా.
Anything else, Kiran? It's already 9 o'clock.
Mackay blade is useful in this obesity difficult intubation.
Okay, Srikanth, nothing specific. If any inputs regarding the facing difficult intubation, anyone can.
డిఫికల్ట్ ఇంటిబేషన్ ట్రాలీలో ఏమేమి ఉండాలి అనేది ఒక లిస్ట్ పెట్టమ్మా గాయత్రి.
ఓకే సార్, పెడతాను.
సో దట్ అన్ని చోట్ల అందరూ వెరిఫై చేసుకుని పెట్టుకుంటారు ఉన్నాయా లేవా అని.
ఓకే సార్. ఓకే.
Srikanth, regarding this LMA, only patient airway secure చేసుకోవడం వరకు అయితే difficult intubation లో okay, but not for maintaining anesthesia in this OSA patient. Sometimes it will be difficult to ventilate, there will be chances of regurgitation. So it is, if possible, we have to avoid using LMA. But
It is a very valid point, Kiran.
Sir?
As you said rightly, it's not maintaining the airway, it is a ventilation. It's a very valid point.
Yes, sir. Only for ventilation we can use, but not for maintaining. Yes. Thank you, sir.
Okay, thank you. We'll end the
Yes.
session. Next week we shall have Shaker Unnada, DNB student session. So we'll know you the speaker and topic soon. Thank you.
Thank you, sir.
Thank you, guys.
Thank you, sir.